didn't try to escape. So in the first part, we talked about what we do in the emergency room for our strokes. In the second part, we're going to talk about what happens once they get to our inpatient service. Um, First thing we're going to talk about is the care depends on whether they got TPA or endovascular therapy or not. The second thing is, this is kind of what we go through all of our rounds, is what type of a stroke is it? And if we know the type, then the next question is what caused it? And then after that, the question is, how do we make sure it doesn't happen again? And then, is there anything else significantly going on with the patient that we need to take care of? Unfortunately, these patients don't leave all their organ systems and just walk in the door with their nervous system. So they have a lot of other comorbidities that need to be managed. If somebody has received TPA, I just want to reiterate this. Blood pressure goals are different, 180 over 105. We do not give any aspirin or any form of DVT prophylaxis except the intermittent like compression devices for the first 24 hours. Then we repeat a CAT scan at 24 hours to make sure there's no bleeding, even if they have no symptoms. BP checks are more frequent, and the most important thing is if there's any change in mental status, any worsening headache, or they start vomiting for no reason, they're getting a CAT scan, because these are the subtle signs that someone's bleeding into their stroke. Okay, if the patient doesn't get TPA, we let the blood pressure run high for the first 18 to 24 hours. In some cases, we even do it artificially. The goal is, unless the blood pressure is beyond 220 or 120, we don't usually treat those blood pressures. You want to give aspirin as soon as possible if the patient has dysphagia or has a big stroke. Rectal is fine. Blood pressure checks and neuro checks are less frequent than TPA patients. We do not repeat CTs unless something has changed clinically. Okay, so then first question is, what type of a stroke is this? The three big ones which we'll talk about is lacunar strokes, large vessel strokes, and when I say large vessel, it's the MCA, AC, or PCA, and then finally embolic strokes. Okay, so this is how I say 57-year-old hypertension, diabetes, hyperlipidemia who presented with a lacunar stroke or who presented with a large vessel stroke or an embolic stroke. So that's the key. So what is a lacunar stroke? Lacune means lake. It actually looks like a tiny lake in the brain. So this thing that's circled in red is actually a lacunar stroke. On MRI, the sequence we look at for strokes is called diffusion weighted. Just a little background about diffusion weighted. What happens in a stroke is your cells die, pumps don't work, water just stays in the same place. When you put that brain in an MRI, that area where the water is not moving lights up. Simple. Okay, that lighting up is called restricted diffusion. So when you read the MRI reports and they say there's restricted diffusion in this area, that means that area is 99% of the time it's a stroke. There's very few other things that do that. So what's happening in a lacunar stroke? So most of the time, these are patients who are hypertensive, diabetic, have sleep apnea, active smokers. Over the years, the tiniest arteries, the perforators that come off the big branches, they become narrow and narrow. And then one fine day, there's a tiny plaque in them that ruptures, and then a clot forms. And then they get a lacunar stroke. Okay, when it's becoming narrower, they get TIAs. So most of these patients have TIAs before they have a stroke. In the big picture, the problem is in the tiniest vessels in the brain, the penetrating vessels. That's what causes your lacunars. Okay, so the second type of stroke is a large vessel stroke, ACA, MCA, or PCA. You can see in this scan that the whole hemisphere is infarcted. It's an MCA and ACA stroke. And the area that I've circled, I don't know if you guys can see it, but this area, where there is supposed to be a carotid is missing. So there is no carotid. On this side, you can see a carotid, and in middle cerebral, there's nothing here. Okay, so this patient had a carotid occlusion. So what causes a large vessel stroke? It's a little different. Okay, same risk factors, hypertension, diabetes, hyperlipidemia. But the way we look at these strokes is when I see a large vessel, I start from the top, I work my way to the bottom. That's what I call the head to toe approach. I'm looking for athero in the parent vessel. that again ruptures and causes a thrombus, or I'm looking for something that broke off or somewhere else and made its way to this large vessel. Either it broke off from the neck, if there's carotid stenosis or a ulcerated plaque or a thrombus in the carotid, or it broke off from the aortic arch or the heart. There's a clot in the aortic arch or there's a clot in the heart, and then it broke off and made its way up to these large vessels. So there can be three reasons why this happens, and this is important because when we come to the workup, you'll see us do all sorts of workup. This is why we do all that work. If you see a large vessel, you're going to look for these three things. Embolic strokes, the problem with embolic is the first scan is what it's supposed to look like, the one on the extreme left, where there's different strokes in different territories. If you see that, you're like, oh, thank you for making my job easy for me. But unfortunately, it doesn't look like that. Sometimes it looks like a large vessel stroke, like the one in the middle. Or sometimes it can look like a Lacunar stroke. So we'll talk about when to think of embolic and what do we do for embolic. But again, the embolic encompasses everything. It can be because of the narrowing of the parent vessels. It can be because of a problem in the neck, or it can be a proximal problem, either in the heart. Sometimes it can be because you have a clot in the leg, and then through a hole in the heart, it made its way to the brain. It's called paradoxical embolism. This is not included in the types of strokes, but this is a very important kind of stroke that we see, and this also pertains to when the patient leaves the hospital. Watershed basically means that we looked at the MCA, AC, and PCA territories. At the border zones of these territories, there's very poor supply. So whenever, for some reason, somebody's blood pressure drops really fast, they tend to get these kinds of strokes. These are called watershed infarcts. Okay, they look like a string of pearls. On the MRI, or on the CAT scan, you can see this. It's like a string of pearls. That's what we call them. The areas that are marked here, they show the watershed areas, and that's where you get your strokes. The symptoms are pretty classic. We call it a man in a barrel. Okay, so imagine you're inside a barrel. Your hands move fine. You cannot move your shoulders. Okay. If you ever see that, that's most of the time it's because of a watershed stroke. And they have language deficits and all that, but that's the classic thing that happens. In these patients, again, we're more conservative with the blood pressure. We let them run higher for a little longer. Okay, so coming to what causes these strokes, lacunar, we talked about it, hypertension, diabetes, hyperlipidemia. Mainly uncontrolled. That's the key word in our stroke workup. You always want to see uncontrolled risk factors. And rarely, like we looked at, it can be embolic. Large vessel, we looked at the three causes. And then embolic, it can be anywhere. You can start from the big vessels to the neck, to the heart, all the way down to a clot in the leg. So again, like what I like to go over whenever I see every stroke is a head-to-toe approach. That way I don't miss something, and you make sure that you haven't missed any treatable causes. In order to look at intracranial lateral, we use MR angios. Most commonly, you can use a CT angio. And then the next thing is the neck. We look at it with a MR or CT angio or a carotid ultrasound to look for stenosis or clots. And then you look at the aortic arch, which is the next big culprit, and then after that, the heart. Most of the time, we stop with the transthoracic. I'll show you guys when we go further. And then again, the search for clots in the legs and all that, that's also on a case-by-case basis. All right, this is a busy diagram, but it's simple once you start on it. So patients on my service, they've had an ischemic stroke. You have to say no. Oh, okay. So the first thing we get is an MRI. At the same time, we get an MR angio just to save time. But usually the MRI will tell you if it's a lacunar stroke, it's a large vessel, or if it's an embolic. We looked at pictures of all three just so you guys can burn into your heads what they are supposed to look like. If they don't look like that, then you should think that something's different. If it's a lacunar and the patient has all these traditional risk factors we talked about, the hypertensive, the obese, the diabetic, the hyperlipidemia, the sleep apnea, the smoking like a chimney, then usually the workup is limited to only three things. We look at the MR angio of the vessels, then we do a carotid, and then we do an echo, we stop. If there's no carotid stenosis, there's nothing obviously wrong in the heart, then our main focus is to control these traditional risk factors. Okay. The same thing with large vessel strokes. If they have all these traditional risk factors and then we do the three things and it's fine, we stop there. Okay, so most of the patients who come to rehab, they'll have three studies: MRI, MRA, echo, and a carotid duplex. That's the reason why. So let's say you get somebody who's young or who's has no comorbidities or who has all these comorbidities, but they're very well controlled. They're on diet, they're on exercise, they stopped smoking 10 years ago. Blood pressure looks fine in the hospital. Hemoglobin A1C is less than 7. Then you should ask yourself, okay, they're doing everything they can. They're on all the right treatments. Why is this happening? That's when you want to work them up further. And some of the things that we do is other things are detailed here. Vasculitis is something we suspect in those cases. Somebody who keeps coming back with stroke and they're on all the right treatments. The diagnostic test is an angiogram. Just take them to the intervention suite and do a diagnostic angio. If the transthoracic is fine, you don't see anything, we might do a transesophageal echo. So you'll see some patients get these. That's the reason why. They don't have the traditional risk factors, they're not seeing the classic picture. That's when we do these extra tests. You always have to think of atrial fibrillation. The thing about atrial fibrillation is 90% of the time there are no symptoms. Contrary to the popular belief that AFib causes palpitations, it almost never causes any symptoms. Okay, if you have a room full of stroke patients, at least 10 to 20% will have AFib and they don't even know about it. Okay. So for that, we have come up with new ways to detect AFib. And the problem is it's paroxysmal. It comes and goes. You watch patients for 24 to 48 hours, maybe 3 days. People might not have AFib during that time. Their heart might say, no, this is nice. There's salt restriction in my food, I'm not stressed out, I'm in bed all the time, I'm not in AFib anymore. But as soon as they leave the hospital, they go back into AFib. Why? The treatment is anticoagulation. You can throw all the antiplatelets you want, all the blood pressure control medication you want, you're not going to scratch the surface of the risk for stroke. We do some extra labs. If somebody is young or they have a DVT or they have having strokes, we do hypercoagulable panels. We have the risk factors for syphilis, we might check for syphilis, and so on and so forth. But that's again on an individual case by case basis. But most of the patients that you see with stroke should get a workup that should involve MRI, some form of head imaging of the vessels, which is an MRA or a CT, what have you not. Some form of imaging of the neck, either a carotid or an MRA or a CT. They should have a transthoracic echo. This is the bare minimum we should see in all of these patients. Okay. Embolic strokes, again, embolic strokes are a completely different workup. If you see somebody who has strokes in different areas, we do the traditional stuff, like the big three we talked about, but we always do transesophageal. Why? If you imagine the heart, okay, the back of the heart is the left atrium, which is the most common cause for strokes. It's usually dilatation or there's a clot hiding there. You cannot see it well with your transthoracic probes from the front. But when you put a probe in the esophagus, you can see it great. Okay, you can see PFOs, you can see clots in the left atrial appendage, which is why if the transthoracic is fine, you're not finding anything, and these patients are having strokes and or they have an embolic stroke, you always do a transesophageal. The other thing, and they all get AFib monitoring. Those are the two that have to happen. Like we will usually say when patient leaves rehab, they need to see cardiology for a Holter. You'll see that in some of our summaries. That's because we have a high suspicion for paroxysmal AFib. And the Holter here is only approved for 7 days, but ideally you want to do at least 30 days of Holter to detect AFib. If there's a PFO, there's a hole in the heart, we want to go a step further because the way that PFOs cause strokes is something called paradoxical embolism. Patient has a clot in the leg because they're in bed for too long, they recently had surgery for some reason. The clot breaks off. Normally it stops in the lungs, but in somebody with a PFO, goes to the left side of the heart, shoots up straight to the brain. So if you see embolic strokes with a PFO, we always get an ultrasound of the leg and an ultrasound of the pelvis to make sure there's no clots. Any questions? I know I kind of breezed through, but remember for the stroke workup, the big three, and then if there's no traditional risk factors, you want the extra workup. If there's embolic strokes, you want the monitoring and the transesophageal echo. Okay, that's kind of the gist. So this is just to reiterate what we talked about. All patients should get, the ones in red are, I think, the most important thing. All patients should get these three. Okay, and that usually tells us if there's a big problem that can be fixed. That's why we do at least these bare minimum 3 studies. All patients get a lipid panel and a hemoglobin A1C. Even if they're not diabetics, you want to see what their hemoglobin A1C is, because most of the time they're newly diagnosed diabetics when they come to you for the first time for a stroke. Okay. So like I said, AFib is very paroxysmal. Okay, it's a moody thing. Sometimes it comes out like as soon as the patient gets to the hospital, you're like, fine, he has AFib, we can anticoagulate. Sometimes it never comes. Okay, when all these patients have extensive workup and we didn't find a cause, we would label them cryptogenic, which means we don't know what the hell is going on with these patients. They keep coming back with strokes. So then somebody said, AFib, and somebody noticed that all these patients would go to the teleservice a few months later with AFib. And they're like, maybe this is what is causing their strokes. So there are two ways to do this. One is the Holter device. You can see in this picture, the person wears it for around 30 days, walks around with it, does everything. Okay. And then, at the end of 30 days, they return it to the cardiologist, and if there's AFib, the chance of finding AFib is almost about 5 to 6 times higher. Okay. I've included the studies in the appendix. You can look over it, and if you have questions, you can let me know. Okay. But now something even newer has come on. This device called the Reveal is the size of a thumb drive. Okay, it goes underneath your skin, no wires, nothing. It's an outpatient procedure. We do it at the bedside. The cardiologist comes, put it in at the bedside. What it does is, if there is AFib, it actually alerts your cardiologist, like alarms. And then it says your patient's having AFib. Then you're done. You call your patient, you say, come back in, you're going to start your anticoagulation. Make sure that you don't have strokes again. Because all the treatments we have talked about till now don't scratch AFib. Anticoagulation is the treatment of choice. AFib, yeah, sure. You can't give, aspirin, yeah, maybe. If you can't give anything else. But otherwise, anticoagulation is the treatment of choice. And these patients have a very high risk of stroke. Very high. Okay. This is what my research is in. I thought I didn't do this slide. But this is something that is ignored everywhere. Okay, sleep apnea is very common. It is very underdiagnosed. Okay, and even if you give your patient a damn CPAP machine, they do not want to use it. Okay, whenever you see patients who are on 3 hypertensive medications, okay, the first thing to think about is sleep apnea. This is the #1 cause of secondary hypertension in this country, okay, probably in the whole world. Okay. So this is the #1 cause of why people with strokes are on 3 or 4 antihypertensives. You put a CPAP machine on them, they're on 1 antihypertensive medication. So most strokes happen during sleep. We also notice that sleep apnea causes increased uncontrolled hypertension. It causes AFib. Okay, it also causes a risk of MI or CVA. It's easily screened for. All you have to do is ask these 4 questions. I didn't even put the other 4 questions because that takes a measuring tape and all that. I'm lazy. Okay, but these 4 questions are something you can easily do. Okay, it's called a stop. Okay, are you sleeping all the time? Like it's inappropriate sleeping. Like you're driving, you fall asleep, or you're talking to someone, you fall asleep, or you sleep all the afternoon, even if you slept 6 hours in the night. Are you tired all the time when you wake up in the morning? Like you've slept 6 to 8 hours, but in the morning you're so sleepy, you want to go back to sleep. Okay, that's most of us, but that's why there are 4 questions. Okay, it just cannot be just tired. Okay. Yeah. So, do you have any episodes of observed apnea, like choking spells, like when you stop? Like if this is something you ask the bed partner, like they have spells where they stop breathing and then they wake up, or they do they snore loudly. And then finally, do you have uncontrolled hypertension or just hypertension? If it's these 4, your chances of finding sleep apnea are going to be really high. Even if you say, okay, I am not going to do these 4 questions, I am too lazy. If you have someone who's morbidly obese or you feel like their neck circumference is very big, they're probably going to have sleep apnea. So the number of referrals, and this is what I did my research on doing this. The number of referrals for stroke patients to sleep clinic is at least at Einstein, is around 5%. And the average sleep apnea incidence is around 30 to 40%. And these are patients that are going to be forever on 5 medications, antihypertensives, which we all know they're never going to take, okay, because it's 5 medications. So you could do them real justice with this. The diagnosis is simple. They come in for a sleep study. You diagnose that they're having apneic or hypopneic episodes, and based on the number of episodes, you grade them. They do a titration study. They put you on a CPAP, and you use it every night.
What's the proposed physiology?
So there's two kinds. I mean, obstructive mainly is that your airway collapses when you sleep. And that airway collapse causes all these things, like the blood pressure shoots up, and then your heart starts going into arrhythmia. And then once you change your posture or something, your airway collapses, or you wake up because you're not breathing, and then your airway collapse is relieved, and then your blood pressure goes down. This
The fluctuation of blood pressure.
And then that puts a strain on the heart, that puts your risk for arrhythmias and MIs also. That's kind of the thing. Central sleep apnea is more common after stroke, so I mean, there's nothing you can do for a central sleep apnea. It's because they have had a brainstem stroke or something. They're not breathing properly, but at least for obstructive, there's a lot you can do. Okay, so we looked at the 3 big kinds of strokes: lacunar, large vessel, embolic. We've looked at the workup. When do you do TEs? When do you sign up for a Holter or for a device? And what are the 3 main things you do on all stroke patients other than the lipid panel and hemoglobin A1C? So what is the next thing? So the next thing is, how do I make sure this doesn't happen again? So what I use is the ABCD. Okay, and this helps me not forget stuff. So A is for antiplatelet and anticoagulation. Most lacunar strokes, large vessel strokes, and everything, they get antiplatelet agents. Okay, the 3 antiplatelet agents we use are aspirin, Plavix, and very rarely Aggrenox. Okay, people hate Aggrenox because it causes diuretics and the pain is soft. Okay, but sometimes we will use. If somebody comes in on aspirin and they've had a stroke and it's not AFib or something related, and you're controlling all the risk factors, you will switch them to Plavix. Okay, if somebody comes in on Plavix and they've still had a stroke, we might switch them to Aggrenox. So you'll see these patients that come to rehab who were on aspirin, got switched to Plavix, or were on Plavix, got switched to aspirin. The reason we do this is there is resistance to these medications based on your genetics. Okay, like even aspirin, based on the dose, like at 160 or at 81 milligrams, only 75% of your platelets are inhibited. Some patients it's fine, but when you give 325, 99% of your platelets are inhibited. So sometimes you'll see it just increase the aspirin from 81 to 325. Okay. Again, Plavix, there is this cytochrome P450 gene that metabolizes it and that's supposed to activate it. If you are a slow metabolizer, if you don't have that gene, your Plavix won't work. So you can still have strokes on it, so we switch the medications around for that reason. The next thing is anticoagulation. Anticoagulation, there is right now no indication to start heparin on an acute basis in the hospital. This was something that was a big controversy up until a few years ago. People would put carotid thrombus on a heparin. People would put AFib patients on heparin drips. We don't do that anymore. The only time you want to put somebody on an anticoagulant, and this is only if we start Coumadin or something, is for AFib. For the other thing we looked at, if there's a PFO and there's a clot in the leg and then it makes its way up to the heart and the brain, paradoxical embolism. These are the 2 big ones for anticoagulation. What can you use? You can use Coumadin, or you can use one of the novel anticoagulants, Pradaxa, Fixaban, or Rivaroxaban. New one is coming out, I think Edoxaban should hit the market soon. We'll talk a little bit about how do you choose it. Okay. So that's anticoagulation. B is for blood pressure. Okay. So blood pressure should be normalized, and we try to do this prior to discharge. Okay, but unless there's a specific reason, like there's severe vertebrobasilar insufficiency, or there's a severe carotid stenosis bilaterally or something, or they have very poor collaterals, That's a very case-by-case basis. But as across the board, you want to normalize your blood pressure. Um, the medications that we use, ACE and ARBs are our number one medication that we go to, followed by calcium channel blockers and diuretics. Okay. Less likely we are less likely to use beta blockers, nitrates, hydralazine, and clonidine. The reason we are less likely to do this is blood pressure fluctuations. Again, if your back's against the wall and you don't have any other medications, we will put people on hydralazine and clonidine, like dialysis patients. I mean, nothing works in them, so you'll like they have no kidney. So sometimes you do put that. Let me talk a little bit about how we treat hypertension. So when I see hypertension, again, I like to keep things simple. There's three axes for hypertension. One is your renin-angiotensin system, which does something to your blood pressure. Again, I'm trying to remember all this system. It's hard. I'm not a nephrologist. The other one is your adrenergic system. That again does something to your hypertension, right? And then the last one is vasodilation. Okay, so these are like the three things. So if I see somebody with hypertension, I'm going to attack the renin-angiotensin system first. How do you do that? ACE or ARBs. We start them on that. And then I say, okay, he's something that's blocking the renin-angiotensin system. Now let's see if I can put a vasodilator. Okay. So I put either calcium channel blocker, or then I put a diuretic on top of that. Okay. And then I say, okay, he's on a diuretic, he's on a calcium channel blocker, he's on an ACE and ARB. Two systems are blocked. The only thing left is the adrenergic system. I'm going to put a beta blocker. Okay, so that's kind of my approach to hypertension without other comorbidities. If someone has CHF, the medication choices will change. You're going to be on ACE and you're going to be on Coreg, because Coreg is what is used for CHF. If you're diabetic with diabetic kidney disease, you're going to be either on an ACE or on a calcium channel blocker. So it's a case-by-case basis, but if somebody just for stroke, you want to look at the three-pronged attack for hypertension. Okay. Your angiotensin system, your adrenergic system, vasodilators, and diuretics, which are kind of clumped together. Okay, so these are the three systems you want to use something for. And I promise you, most of the time, your blood pressure is going to get dropped. Okay. The other thing is you want to space out the medications night and day so that you have a better blood pressure control. And if there is a polypill, like some medications have 3 antihypertensives, please feel free to use them to encourage compliance. Okay. Blood sugar, your goal hemoglobin A1C should be less than 7. If somebody comes in with a hemoglobin A1C of 11 or 12, we're putting them on insulin right off the bat. Okay. The important thing to know is beyond a hemoglobin A1C of 9, insulin doesn't work. I mean, not insulin. Oral hypoglycemics don't work. Okay, and this is a rule of thumb. All oral hypoglycemics bring down your hemoglobin A1C by 1. So if your goal is 7 and somebody's hemoglobin A1C is 11, how many oral hypoglycemics do you need? There is no way they're taking 4 oral hypoglycemics with their aspirin, with their statin, and with their blood pressure. So we usually end up putting these people on insulin. We try to keep it to once a day. If somebody is non-compliant, we start with Lantus, but most of the time, full-fledged Lantus with asthma. Cholesterol. So we do want the LDL below 100, and if somebody is very high risk, recurrent strokes, recurrent coronary artery, severe CAD, multiple MIs, you want the goal below 70. Every time these patients come to stroke clinic, I have a lipid panel every 6 months. The only 2 statins that have worked in stroke, and this is based on the Sparkle trial, is Lipitor and Crestor. Okay, Lipitor 40 or 80, Crestor 20 or 40 milligrams. These are the only doses we use. Somebody doesn't have insurance, we might use similar statin. But otherwise, there should be no other reason they should be on other statin. If they cannot tolerate it, maybe. But otherwise, these are the only 2 statins you should be seeing on all your stroke patients. Last one for D is DVT prophylaxis. All patients across the board should have at least 2 forms of DVT prophylaxis. Sequential compression device and either Lovenox or heparin. Heparin is used if the GFR is low and you can't use Lovenox, otherwise we like Lovenox. Okay. So ABCDs. Yeah.
The patients are on one of those newer agents, Daxa, Rivaroxaban. As far as how long do you have to be on that before you're starting a chemical prophylaxis for the heparin or
So if they're already on it, so those medications start acting immediately. You don't need to be on DVT prophylaxis if you're taking apixaban or rivaroxaban or prophylaxis.
within 1 day?
Oh yeah, within few hours. So that's kind of the benefit and the downside of these medications. Like start acting immediately, but they wear off immediately, which is why some of these meds like Pradaxa, apixaban, they're twice a day. So unlike Coumadin, which once you get to therapeutic, if you miss a dose here and there, you're like, okay, fine, no, one dose won't make a difference. But in these meds, if you miss one dose, you're screwed. They actually patients who are on Pradaxa and who were taking Pradaxa, who used to miss one dose, they would come in with a stroke, just one dose. So it's kind of tricky, but they start acting immediately, and you don't need to be on DVT prophylaxis if you're on anticoagulation already with any of these agents. We just put the SCDs. Normally in the medical service they use either or, but we found that even if we do either or, very high risk of stroke. I mean, very high risk of DVT and PE in stroke patients. So we do both. And I'm currently doing my fellowship at Jeff, and they actually do like ultrasounds of everybody's legs who come into the hospital with a stroke, and they do them every week. Like if they're in the ICU, every week they get a DVT ultrasound, like ultrasound of everyone's like legs just prophylactically, because it is so high and it is so rampant. And usually the problem is they go to rehab, they already have a DVT, even in spite of being on the SCDs and the Lovenox or heparin. Then they exert and then it breaks off. And they come back with a huge PE. Okay, see it happen all the time. Okay, we don't do dual antiplatelet. If you see somebody on dual antiplatelet, it's only temporary. Please be mindful of this, because you can give somebody Coumadin rather than give them aspirin and Plavix. They're less likely to bleed. Okay, if you leave somebody on both aspirin and Plavix, bleeding risk is pretty high. The only time we do it is for intracranial lateral, which we looked at, and cause large vessel strokes or embolic strokes. The only other place we also do it is lacunar strokes, but this is only for the first 90 days. After that, they need to be on only one agent. We never leave them on two forever. Okay. If somebody has stents and all this, and for other reasons, they might be on dual antiplatelet, but not from the stroke point of view. There's only two indications. Okay, because what happens is these patients are going to be on two antiplatelets forever. They're going to keep following up with their PCP, will never take them off, and then they bleed and they come back to us. Like I said, Agrinox causes bad headaches, but sometimes, if they've already been on aspirin and Plavix and they're taking it, it's very important to make sure of that. Then we switch them out to Agrinox for antiplatelet agents. Let's talk a little bit about the novel agents and the Coumadin. So all the novel agents cause lesser intracranial hemorrhage. And I say intracranial because GI bleeding is the same. Other bleeding from like superficial bleeding is the same. So it's not like the newer agents cause lesser GI bleeding or anything. It's the same across the board. But they do cause lesser intracranial hemorrhage. Okay, so that's the upside of the novel anticoagulants. There's no need for monitoring. So these are my go-to medications in somebody who's young, who's active, who cannot afford to take off work every week to get their INRs checked. That's somebody I would put on novel anticoagulants. But if somebody, I don't know if they're going to take it, they don't have a good track record of being compliant, I'm probably going to stick to Coumadin. Okay, because I have a way of watching Coumadin levels, but I don't have a way of watching these novel anticoagulants. There are things coming out, but before they become mainstream, it's going to take a while. There is lesser drug interactions. When these agents came out, people said like no drug interactions. Unfortunately, that is not true. So you can use any of your apps like Medscape or the drug interaction checker. There's a group. It's a very tiny group of meds. It's called the PGP, the medication that act on the P-glycoprotein. Those are the meds that affect the levels of the newer agents. So just be very careful when we see somebody on these newer agents and multiple other meds. when you see CKD or ESRD patients, all the data is made up. Okay. Prophylaxis said, oh, okay, you know, if the GFR is this, we're going to half the dose. Where did that come from? Because all the trials excluded GFR, like ESRD and CKD patients. The only medication that has looked at this is apixaban and digoxin. They have looked at CKD patients, stage 3 patients. They actually did a subgroup analysis. Although I never buy into subgroup analysis, but at least they did. And they didn't show any bleeding or anything. So if I have a CKD patient and it's stage 3, I pick apixaban. Okay. So this is kind of like and the other and last important thing which I didn't put here, I don't know why, because I was making this late last night, is there's no reversal agents for this. Okay, but let me ask you this question. Would you rather have lesser bleeding in the first place, or would you have a bleed and then get it reversed in your brain? Yeah, so you would rather have lesser bleeding, because once you've had a bleed, I mean, come on, who are we kidding? If you've had a huge bleed, I can reverse you all you want, the bleed's still there. No, I'm not going to poof, and then I reverse you and all the blood gets absorbed, right? No. So when people ask me that there are no reversal agents, this is what I tell them. I'm like, take your pick. I mean, would you rather have a humongous bleed in your head because your INR levels are all over the place, and you can't adjust your hormone levels, or would you rather have lesser bleeding? I would rather have lesser bleeding in the first place. So that's kind of the benefit of these agents. It depends on how you look at it.
The two ones I played with it for the short period of time, I imagine you drop off the products and continue the aspirin afterwards, right?
It depends. Like, let's say they were on aspirin, they were compliant, and then they had their stroke, we'll do dual and we might switch them to products.
Okay. Even if they were just on the 81, you would prefer that versus increasing that?
And again, there is no evidence for this, and each person would do differently. They might say, okay, let's just bump up the aspirin to 325 and you're not wrong in doing either. Lifestyle modifications, the thing that we always want to do, but can never happen with our patients. Again, every time my stroke patient comes, I go over this, and then they come back, I go over it again. But some patients, I was surprised. Like, some patients actually listen, we can actually make a difference. So what I usually tell them is, you do 30 minutes, 5 days a week. If they can get a stationary bicycle in front of the television, that's the best thing. Okay, that's what I tell all my patients. As long as you're sitting and watching TV, might as well sit on the stationary bicycle and watch TV. Okay. Some of them use it for hanging clothes and drying clothes and stuff. One of my patients, I swear, like one of my patients, like husband brought a picture of it with like all the clothes hanging on it and stuff. But I was like, but still, it's worth it. Sodium restriction, you do want to do less than 2300 milligrams per day, and this translates to as low salt as possible. Okay, that's what I tell my patients. When I try to explain how many spoons of salt, I lose them. So I tell them, try to keep salt down to a minimum. The other thing I tell them is, in diet, I tell them 5 days of the week you live like a saint. Okay, fish, baked chicken, salads. Saturday and Sunday you eat whatever you want, or how much ever you want. Okay, as long as it's not dangerous levels of state. Okay, but yeah, that's what I tell them, and they seem to like it because it's like a reward on the weekend for what they do on the weekend. Kind of helps them balance things out. Alcohol, I never tell my patients 40 drinks per week because they're going to have 40 drinks per week. So I always tell them like, nothing more than a glass of wine, or don't drink if you can. Okay, I don't have that many patients who are into wine or beer. And 9 drinks per week. Okay. But never tell them the maximum number. Okay, they're gonna say, okay, 14. I'm gonna go with 14. Okay, so I don't know if you guys can relate, but this was my story of my life at residency. I mean, those guys were beat down. They would hold 6 pages, and, like the pants were falling off because the pages had too many pages and whatever. Reminded me of Batman, like utility belt and stuff. But anyway, so when do you call a neurosurgeon in inpatient? So we talked about when it's an emergency and when you need to call a neurosurgeon back. So I said everybody gets a carotid duplex, right? Because this is the one thing that you can fix and will make a lot of difference for the patient. Okay, until they come back again with it because they're not taking their statins in a few years, but at least few years. What's marked here in red is the internal carotid, and you can see there's a severe stenosis. Okay, whenever the stenosis is more than 70%, there's a very good advantage of doing intervention, which we'll talk about. Okay, so there's two interventions, and there's a lot of confusion. Sometimes you'll see a patient who gets a stent, and sometimes you'll see a patient who goes to the OR and gets an endarterectomy, which is basically they remove all the plaques in the neck. Okay, in the stenosis part, they just fish out all the plaques. So when do you pick this one? First thing is you need to be symptomatic. If you're asymptomatic, we're not going to talk about this because stroke down. If you're symptomatic due to carotid stenosis and it's more than 70%, that's when you take these patients to either of these procedures. It's more beneficial if it's done sooner. So you don't want to sit on these patients for the next few months and then 6 months later you're like, yeah, let's open up that carotid now. What you want to do is that ideally within 2 weeks. When do you hold off? If there's a big stroke in the brain, that's when you hold off. Because once you open this vessel, it's like a dam that's been a broken dam, like the water or the blood just floods back in, and that's when you have hemorrhage. So you hold off after 4 weeks, but beyond that, there is no reason not to do it. 4 weeks is when your blood-brain barrier seals up, you're less likely to bleed. That's where the number 4 weeks comes from. That's also the number when we start anticoagulation in big strokes. The 4 weeks comes from that. So you can do either or. CEA or stenting or endarterectomy. It depends on what you like more. Would you like an MI or would you like a stroke? See, this is the talk we have to have with patients. I go to the patient who are like, do you like another stroke or would you like a tiny MI? Take your pick. But anyway, most people say they would rather have another MI than a stroke. But anyway. So the trials that compared stenting and endarterectomy showed that endarterectomy is better because it causes lesser strokes. It does cause more MIs, but when they say MI, it's an increase in troponin. Most of the cases were an increase in troponin, not like intervention, stenting, not that bad. Okay. Other problem with stenting is the people tended to come back with stenosis of the stent, and then they had to go back to the operating table again, and they needed another procedure. So reprocedures are high. CEAs are more ideal in older patients, which was surprising. We were like, old people, just stent them. It's non-invasive. It's going to be better. It actually was worse. So the endarterectomy is preferred in older patients. When do we do stenting? Younger patients. Okay. Anybody who's received radiation because their neck is a mess, they have stenosis everywhere and it's uniform, you're not going to take off the whole vessel with your surgery, so that's when you stent people. Prior neck surgery, because again the landmarks are all screwed up, your surgeon's still looking for the carotid, like how 45 minutes into the procedure is like, okay, and long lesions. Like I showed you that tiny stenosis, that's in a small segment, right? That's ideal for endarterectomy. But if there's a huge stenosis going all the way up to your middle cerebral, you're more likely to do stent.
When you say old and young, what's the
older the better. So below 60. So below 60 people tended to do better with stenting. Beyond 60, especially people in their 80s, again when the trial finished, but people tended to do much better with endarterectomy. It's because they were having lesser strokes. And the most important thing, which I did not mention, is that this kind of, it's important, but it's not as, it depends on your center's mortality. You want to send people where the mortality is less than 6%. You want to send your patients there. If you know somebody who has stenosis, you want to find out which hospital has the least mortality and send them there, because this is very operative dependent. Okay, that MI, that stroke risk, everything, it depends on who's doing the procedure. If you do more procedures, you're less likely to do that.
How do you find those numbers?
They're online. You just say like endarterectomy mortality rate and stenting mortality rate. You get the numbers for every hospital. Okay? We're below the number. like 9 cents below the national average. And usually, if you're above, you get audited and then you get evaluated, and then sometimes they close down the program. So the NASET was the trial that got endarterectomy approved. Okay, there's actually a second phase, CREST-2, and is happening right now, but that's a different trial. So 65% of the patients, the absolute, like the relative risk reduction, 65%. The last time I saw that number huge, I've never seen that number. I'm sorry. Okay, but the important thing you have to understand in this is this trial happened back in the late 90s, early 2000s. Can anyone guess how many patients were on statins at this time in this trial? Pick a number.
5%.
20%. Not 5%. Like, come on. 5%. Oh yeah. Oh yeah. I mean 5% too low. So and again, 5%. What do you think they were like? They were like just like no treatment, control group, like just no medication. They named the group medical therapy group, man. I have to at least give some people status. But the important point is it's only 25%. Because now when we look at these patients, you put them on statin, most of the time their stenosis goes away in a few months. Okay, so that's why asymptomatic stenosis is much more trickier. We usually tend to do medical therapy. Before anything, anytime the surgeon sees a stenosis, they're like, let's open it up. And then that was turning bad if it was asymptomatic. So in the trial, like I said, I mean, everything was much better in the surgical arm. And like strokes, all-cause death, mortality, everything was better.
You're saying statin actually improves the stenosis.
Oh yeah. You'll see patients who are not like 70%, they're like 50 or 60% or even 40%. You'll see like some of them with the statins and with the lifestyle modifications, which are harder to do, but if they do it, you'll see stenosis get better. You will see, especially in women. When we take asymptomatic women and they try to stent them or do endarterectomies on them, if they're asymptomatic, they tended to do much worse than just medical therapy. With aggressive medical therapy, they did much better. So, asymptomatic stenosis is a different topic, and that's why we're more picky in who we send for procedures if they're asymptomatic. If you're symptomatic, yeah, you need to open it up rather than do medical therapy.
Even if the plaque is calcified?
Yeah, even if the plaque is calcified. So the problem with our imaging studies is they might show the calcified plaque. What they won't show is the ulcerated plaque that's right next to it, because it's an ultrasound. The calcified plaque is giving off all signals that's blocking everything else. So once the surgeon gets in there, there's like a huge chunk of stuff that needs to come out. And again, the other last thing is you want a life expectancy of at least 5 years. Because for the benefit to be seen, and you saw the curves, right? It took a while before the curves like separated out. That takes around 5 years. So if somebody has terminal cancer, or if their life expectancy is less than 5 years, you don't do this. Now finally, PFO. Okay, PFO is supposed to be a hole between the right and the left atrium that's supposed to close at birth. Sometimes it just stays open. Most of the time, it doesn't do anything. I mean, in this room right now, there are at least 25% of you has a PFO. Okay, the normal incidence of PFO is 25%, and this was in healthy population that they looked at autopsy series in. 1 in every 4 people has a PFO, okay, but they never come to the hospital. But sometimes you have a stroke, and then when we do all this transthoracic and transesophageal, we find a PFO. Having a PFO doesn't mean it caused a stroke. That is the only takeaway point from this. Okay, so you have to be very, very careful. Okay, because back in the early 2000s, people said, "Oh, surgeon, cardiologist said, oh, there's a hole. Let's close it." And then bad things happen. So there were 3 trials that looked at this. Okay, and the problem these trials failed is they were not picking. They did not pick patients who had just PFOs causing strokes. They picked all sorts of patients. Lacunar strokes with hypertension. I mean, hypertension is causing this, so why would you pick these patients to close the PFO? Doesn't make any sense. So these were 3 big trials. All of them failed, as expected. All of them looked at closing the PFO versus medical management required. So we don't close PFOs anymore. Okay, if you do find a PFO, like I said, you look for an embolus in the legs or in the pelvis with an MRD of the pelvis and an ultrasound of the leg. And the only other thing you do is look for AFib, and then you treat them with aspirin. Nothing. Okay, we will. I think in 3 years we've closed one patient who kept coming back with PFO and nothing else. No hypertension, no diabetes, nothing else. They kept coming back. They were on aspirin, they came back. They were on Coumadin, they came back. We said, fine, let's close the PFO. But otherwise, okay, the standard of care right now is just antiplatelet. Okay, you guys still with me? We're almost done. So we talked a little bit about what happens in the emergency room, what are the things that run through our mind, TPA, intervention, blood pressure, sugar. And then when we talked about once the patient gets into the inpatient, what are the things that go through our mind? Again, like what causes, what type of a stroke is it? What caused it? What is the workup I'm going to do? And then how am I going to treat this so this doesn't happen again? So we looked a little bit about what's new in AFib, the monitoring devices we're using. We looked a little bit about PFO. We looked a little bit about sleep apnea, which is again very new. We're actually going to start a trial with high-resolution pulse ox to detect sleep apnea while the patient's in the stroke care. So take-home messages: stroke care is highly individualized. You can make a recipe for any patient, for any other condition. Think of it: GI bleeding, hepatitis, coronary artery disease. There isn't much difference between two people with coronary artery disease. Both of them have a LAD disease, you treat them the same. But you cannot do that with stroke patients. You can have a lacunar stroke and the person ends up being vascularized. So that's why stroke is so interesting. Okay. TPA is approved for within 4.5 hours. Okay, up to 3 hours it's FDA. Beyond 3 hours it's AHA and the American Stroke Association approved. So we give TPA. TPA makes things better 3 months down the road. Endovascular with TPA is standard of care now. Okay, if you are at a center that doesn't do it, you have to send patients to a center that does it. That's what most centers end up doing within 4.5 hours. And up to beyond 4.5 hours, you can still do endovascular up to 6 hours. You only do it if there's a huge clot in your head that can be fished out and there's a big penumbra that needs to be salvaged. Once you do it, the blood pressure is different, everything's different. Basilar artery clots, and these patients come in usually comatose. Okay, you can open up the vessel up to 24 hours. So if you see somebody 6 hours out or 8 hours out, even 10 hours out, depending on a case-by-case basis, we will take them to the OR and we will open up the clot. Again, always ask yourself when you see these patients, what kind of a stroke is this? Is this lacunar? Is this large vessel? Is this embolic? And if it's each type, what am I doing to make sure, what is being done for these patients? What workup is done? What needs to be done? And what they need to be on in order to make sure this doesn't happen again. Out of all the things that is neurology, take MS. You start them on one medication, they go out, they come back with a flare. Fine, you switch the medication. Take seizures. If they've had a few seizures, you try medication, it fails. Okay, fine, they come back. Okay, very few people, neuromuscular disease. You start some regimen, it doesn't work. Fine, you come back with myasthenia flare again. There are very few conditions where you come back with devastating consequences other than stroke. Okay, there's very few conditions that do that. So when you see these stroke patients, getting it right is the most important thing you can do for them. Yeah. Workup, think head to toe, and always think about the ABCDs of treatment. A is antiplatelet, anticoagulation. B is blood pressure, blood sugar. C is for cholesterol, and then D is for DVT prophylaxis. Okay, and then N is for if they need induced. This kind of something. Yeah. Okay. Hopefully, Star Wars.